Okay, welcome everyone. We're a small group in the room and a small group out the room, but welcome everyone nonetheless. We've managed to negotiate the switch from load shedding. I'm Leslie London. Welcome to our new meeting on the experiences of deaf people under COVID, making a difference through research. So we have a presentation by a former SPH student who did a dissertation on this research, and we're very glad that Nafisa Mayat has joined us from the Disability Studies Division in Health and Rehab to be a respondent, and hopefully we will be able to see the presentation, which is now disappeared.
Oh, there it is.
Yeah. Okay, so we all set, and let's not fiddle with anything.
Yeah.
And so I think you'll be able to see your screen in a minute. If not, you might just have
I
to...
can put it. Okay, yeah. It's okay.
Okay.
If I can.
Well, we're holding thumbs. That technology will not fool us. Shows you how important it is.
Oh, there it goes. Yeah.
I'll hand over to you, Charlotte.
Okay.
Thank you, everyone.
Okay, great. Hi, everyone. My name is Charlotte. As Leslie mentioned, I was one of the MPH students a few years ago. Okay, so this presentation is about what I did for my thesis. So the experiences of deaf people under COVID making a difference through research. So for some background, as we probably are all aware, socially disadvantaged populations, including persons with disabilities and linguistic minorities, have suffered significantly throughout the COVID-19 pandemic. So for example, one study found that the population of persons with disabilities during a crisis is 2 to 4 times more likely to die, or the mortality rate is 2 to 4 times higher than that of the population without persons with disabilities, which they note is usually more so due to discriminatory policies and practices than the person's disability itself. And then it's estimated that there are between 500,000 and 1.5 million deaf South African Sign Language or SASL users in South Africa, which equates to about 0.84 to 2.5% of the population. And then disability representatives were not included in the disaster management committees at the beginning of the pandemic. And as such, all of the developed regulations failed to address the unique needs of persons with disabilities. And then, as we're all aware, South Africa implemented one of the strictest lockdowns in the world. And then the reason why we focus specifically on the deaf population instead of just doing a larger disability study is because the centrality of language for deaf people and the deaf experience is often overlooked in larger disability studies. Okay. So then the aim of the study, or kind of the concluding, so while there's evidence from other countries that there have been negative impacts during the pandemic for deaf people, there's currently very little research published which seeks to understand the experiences and impacts of COVID for deaf adults in South Africa. So the aim of this study was to assess the impact of the pandemic response measures on deaf persons' access to pandemic-related information, ability to communicate, and access to health and social services. And then the objectives were, one, to explore the perspectives, attitudes, and experiences of deaf people on the implementation of the COVID regulations, so masking, hand hygiene, social distancing, and also the lockdown. And then secondly, to assess the impact of COVID policies on deaf persons' ability to communicate, access to and quality of health and social services, and then access to COVID-related information. And then for the study design and recruitment, so we employed a qualitative descriptive methodology, and then participants were recruited through the Deaf Community of Cape Town, or DCCT, using purposive sampling. And just to give a little bit of information about DCCT, so they're an NGO founded in 1987, basically by deaf people for deaf people. So they The aim is to kind of support deaf people in the Western Cape. So they provide counseling services, like skill building and education programs, and then also social engagements. And then they were chosen as to kind of partner with for this study because of the longstanding relationship that Leslie and other UCT researchers has with DCCT. So they were just easily accessible, especially during COVID. And then also the DCCT has past experience with helping conduct and facilitate research. And then the inclusion criteria were adults over 18. They had to be living in Cape Town. They had to be audiologically deaf or hard of hearing, and then identify as part of the deaf community and primarily communicate in Sasol, and then also agree to comply with COVID safety precautions. And then funding was also provided by Equal Health for Deaf People, which is an NGO that works to support and advocate for the right of accessible healthcare and health-related information for deaf people. And then for data collection, so data was collected through semi-structured interviews, and the interviews were held at the DCCT Center in Field. And then they were conducted in English and Sasol with an interpreter. And then each session and the consent process and the interview itself were videotaped with one frame on the interviewee and one on the interpreter. And then I also created observational field notes in a reflective journal to act as complementary methods of data collection. And then this is just a little diagram to give you an idea of kind of what the room looked like. So the top photo is what the interpreter looks, or the frame of the interpreter. The bottom one is one of the participants. And then we were all sitting in kind of a triangle so that we could all see each other clearly. And then just briefly on the data analysis. So I transcribed the interviews from Sasol into English, and then we used thematic analysis using NVivo, which was done deductively and inductively. And then overall, we had three main themes emerge, which were information provision, interpersonal communication, and disruptions to daily life, and then their experiences in the health system. And then just some demographic results. So overall, we had 15 participants. Their ages range between 26 and 67, and then 10 were women, 5 were men, 6 were unemployed at the time of the interview, 9 were employed, 9 had either at or below a grade 8 education, and then 6 had between grades 9 and 12. And then we also asked about their living situations. So 9 lived only with hearing people who had little or no Sasol knowledge. 1 lived alone, and then 5 lived with at least one other fluent Sasol user. And then for theme 1, which was information provision. So at the time of the interviews, participants said that they had a general understanding of what COVID was and what the protective measures were. But all of them noted that in the beginning months of the pandemic and the lockdown, they were largely in the dark and had very little information. And then most of them noted that this was because they were stuck at home, where they lived with people who weren't able to communicate fully, so they didn't get access to that information that was shared via the presidential addresses and all of that. And then they also noted that because of this information deficit, many of them did not adhere to the preventive measures or lockdown regulations. So they would go see their friends, they wouldn't wear a mask. And then we also found that DCCT was pivotal in providing information to the deaf community. So at the beginning of the pandemic, they weren't considered an essential service. So they weren't allowed to open up in person until level 3. So during the time that they were kind of all online and closed, they would take news from the presidential addresses and from the Department of Health's website, and then create videos in South African Sign Language, and then disseminate those through WhatsApp and Facebook. And then they had a few opportunities to go and do outreach events that they got permission from the Department of Health to do that, so they could reach specifically in kind of a little bit north from Cape Town, where it's a bit more isolated and a lot of deaf people don't have access to the internet. They went and did outreach events there to provide information. And then this is just a quote from one of the participants stating, I had no information while I was staying at home during lockdown levels 4 and 5. After a long time, I came to DCCT and they shared information in Sassel. And I was like, oh, it's corona, it's dangerous, it's an infection. So I say thank you to DCCT because it was only when they started sharing information that I understood. After I understood, I became very strict and careful. And then theme 2, so like many others, a few of the participants had a loss of income due to either being laid off or their business closing at the beginning of the pandemic. And then many expressed fear around the virus itself and losing loved ones. And then also many, as I mentioned earlier, 9 of them lived with only hearing people who had little to no Sassel knowledge. So a lot of them experienced social isolation at home, especially in the beginning of the pandemic, which was really hard and kind of a unique experience for deaf people. And then they also, because they couldn't leave, they also lost contact with their signing community. So they really had a hard time keeping in touch with people, especially because a lot of them felt they had a more difficult time than the average hearing person because they, I can't talk on the phone, and then being able to video call requires more data, which is more expensive. And then also language barriers limit their ability to text back and forth or message. And then the pandemic response measures, so masking, social distancing, exacerbated existing communication barriers when communicating with hearing people. So obviously these barriers are not new, but being unable to lip read because of masks made things more difficult. And then also having to rely then on written communication created issues like language barriers. So they didn't understand what was written, the other person didn't understand what was written. And then also social distancing rules. A lot of people were scared to pass pens and paper back and forth or get close enough to see what the person was writing. And then uniquely, we also found that the pandemic response measures created novel challenges when communicating with other deaf people. So they noted that because a lot of grammar and sign languages is on your face, so when the mask covers a big portion of your face, it was hard to see kind of the tone of the sentence. So a lot of times there would be miscommunications around that. And then in terms of social distancing, they also noted that a lot of them had difficulties, for example, getting another person's attention. So the norm in deaf culture is to tap them on the shoulder or flick a light switch, which both of those would, you'd be touching them or touching like a heavily touched surface, which created challenges as well. And then these are just 2. So the left is sorry, can you guys mute, please?
Somebody's sound is unmuted. Can you mute, please? Oh, it's maybe just.
It's fine. Okay, so the left quote is if I ask people to remove their mask, people as in other hearing people, they refuse, so I have to write things, but some would get angry. They'd say, what does this mean? What is this about? Sometimes you just give up and have to go to the next person until you find someone who's understanding. And then the right quote is, you must take off your mask when signing with other deaf people. They need to see your lips and mouth. It's part of the language. If you cover your mouth, they get closer to you and think you're angry because the mask is covering your face. And then you have to take it off and say, no, I'm not angry. And then theme 3 was just about their experiences accessing health services. So out of the 15, 14 of them did go to access health services at some point before the interviews. And sorry, I actually forgot to state in the methods, the interviews were conducted between September and October of 2021. So of the 14 that accessed health services, 10 wanted to have an interpreter, but were unable to because interpreters were not considered an essential service, so they weren't allowed to go in with them. A few people said that they didn't even try. Several of them did try and bring one, and the interpreter was denied at the door. And because of this, many had negative experiences with healthcare workers who denied the interpreter and then also refused to make accommodations like taking off their masks to speak so they could try and lip read, or rushed through written communication. So there was a lot of communication barriers. Some of the participants invented creative strategies to navigate these barriers. So for example, one participant decided to write deaf on his medical folder so that when the nurse came out to the waiting room to call him for his next appointment, they saw he was deaf, so they would just hold up the folder because he wouldn't be able to hear them, and especially also with the mask. And he said that did help a bit. And then because of this communication barrier, a lot of them didn't fully understand their prescribed treatment, and which evoked feelings of fear and mistrust, and also non-adherence to their medication or treatment schedule. And then 2 of the participants also had positive experiences where staff agreed to remove their masks to facilitate communication or allowed an interpreter. And both of these 2 participants went to the same health center, and one of the staff at that health center has a deaf family member. So they've done work to educate the rest of the staff on deaf culture and how to deal with a deaf patient. So both of them noted that it was because of that existing relationship and awareness among the staff. Oh, and then we also asked them about their vaccine experiences. So all but one had received the vaccine. Most of them went with DCCT, who arranged to have an interpreter go with them to the vaccine site so they could communicate effectively. And then among those that were vaccinated, 11 said that they wouldn't have gone if it hadn't been for DCCT sharing information and providing the interpreter to the vaccine site. The two that went alone had a difficult time navigating the process and felt inadequately informed, but also decided to get it anyways because they wanted to protect themselves and their families. And then this is just a quote from one of the participants who had gone with DCCT. So he said, "If I hadn't had an interpreter there, what if I couldn't see my name called and missed my appointment? What if I said yes, but didn't know which vaccine I'm getting? What if I had an allergic reaction because they didn't ask the right questions or I didn't understand correctly, so gave the wrong answers?" Which just highlights how important it is for them to have proper communication and information. Okay, so overall, we found that discriminatory practices and communication barriers in the health system worsened during the pandemic. So the refusal of interpreters, the imposition of mask mandates, and then difficulties with written communication compromised the participants' quality of care, and then also infringed on their right to access health information in their preferred language, and also their constitutionally enshrined right to access quality care. And then also the 2 positive experiences that participants had because of staff awareness just highlights how important it is to prioritize education and cultural awareness among providers, which can both improve their interaction and also empower deaf patients in the health system. And then with the lack of accessible and timely information in SASL was also found to be a global issue, both among other deaf communities and also just linguistic minorities in general. So many other studies have found that linguistic minorities report more misunderstandings of COVID information, and also less adherence to things like mask wearing and stuff like that. And then other studies, and also our study, found that language concordance, so speaking in their native or preferred language, has increased both understanding and action. And then lastly, our study highlighted the amazing work that DCCT did throughout the pandemic in supporting the deaf community, providing information, and just generally filling the gaps that were left, which was found by a lot of other globally, a lot of other disability persons organizations and NGOs in general worked really tirelessly to fill those gaps. And then in speaking with the DCCT staff members during the interviews, they also noted that they were both left out of initiatives by government, but also community initiatives. So I don't know if you guys know, like the cans that were created during COVID. So one noted that even though with these cans, and it was a wide network of all of these various actors and NGOs that were really doing amazing things, but no one consulted with DCCT or with other disability persons organizations to kind of facilitate them also getting access to that, to those resources and that support. And then, so just to conclude, so as I noted, the provision of public health messaging in one's native language and from trusted sources like DCCT increases the support for and adoption of such information. So it's really important that going forward, both government and community level actors use this information to make sure that we are providing information in native languages and in the most accessible forms. And then secondly, deaf people and community organizations need to be actively included in national and community level response planning and implementation efforts during a crisis, as they know their communities best. And then also increase knowledge of deaf health needs and deaf cultural awareness among healthcare workers can improve deaf patients' experiences and outcomes in the health system. And then just a few reflections. So there were a few challenges of conducting research during COVID. So we decided to do this work in person, just given that the modality of sign languages is a lot easier to do in person. But because of that, so the data collection was conducted under level 3, but it also limited the researcher, me, to recruiting participants that were already associated with DCCT and that were already there. And then working with DCCT overall was a really great experience. There's always a little bit of a limitation when working across a language barrier and with interpreters. So there's always instances where meaning can get lost in translation. And then also with the modality of sign languages, it's a lot harder to do back translation. And then also, again, it being COVID. So back translation is a lot more difficult. And then, but overall, it was a really great experience, and DCCT's past experience with conducting research really helped facilitate the experience. And yeah.
Thanks so much, Charlotte. Nafisa, you were going to make a few comments. I don't know if you want to come up here because the people on the teams won't be able to see you or hear you. Sorry about that, because let me just point this. There we go. Okay. Right.
Thank you. Thanks so much. And thank you, Charlotte, for your research. I think it's a very interesting area. Again, as you say, one that's not researched enough. And I think why it's critical is that it's coming from within South Africa and Africa, because as you said, most of the literature is out of it's always the literature that we take from North. So I think that's very good. I just want to ask your reason. How did you get to this, topic, this focused research area around this in particular?
So I, when I was in my undergrad, I majored in deaf studies and American Sign Language. And then at one of I did my MPH in the environmental health track, which is Leslie's track. And then at one of the meetings, I think we had to introduce ourselves. And I said that when I was introducing myself, and then Leslie came up after. So I have like a prior knowledge of working with the deaf community and being a part of the deaf community. And then Leslie has his connections with DCCT and has done a lot of research with the deaf community in Cape Town. So then kind of.
Okay, yes, I know public health at SPH, they have worked very a lot around this area in trying to get sign language interpreters into the health system. Why I'm asking that is often we come in as non-disabled people researching an area within the disability community and not really realizing that that is a need within the community. And as follows to my next question, is you partnered with DCCT, and how was that partnership structured? Just want to like, you coming in and as a researcher, again, we are often seen as the other, because we're going into that, we all experience that, doing research in within the disability field. And how did you find yourself in that space? So I'm asking, why am I seeing how you come to the question? But was it a need that was reflected from the deaf community, that this is an area that needs researching?
Yeah, so and maybe you can explain if I don't more. So in the beginning, I think that Leslie spoke a lot with Equal Health for Deaf People, and they had a few people in that NGO who I believe are deaf, or at least have access to the deaf community and relationships with, who were the ones that brought it up to begin with. So they came to Leslie saying that they wanted to look into this area. And then after we discussed kind of what the some ideas for what we could look into, I had a meeting with DCCT to talk to them about kind of the plan and if they think that there was anything in particular that would be or that's important that would be good to look into. And then throughout the process, had more meetings with them, sharing my the things that I found, if they think that it's like reflecting correctly the experience, if they think anything needs to change, or if I need to, go into a different direction.
Thank you very much, because this is, as I say, a very important area, and we have to check ourselves all the time within this space. Sometimes we think we know what the community wants, and it's not actually what they do want. The other observation, I mean, I'm listening to this, and it's just reverberates with what we know around exclusion for persons with disabilities, and for deaf and hearing impaired individuals, it's much more difficult where communication is concerned. And I'm just trying to imagine, and I can't, so the president talks and we have a sign language interpreter there, so they have the broader picture, but the deeper stuff and the deeper exclusion that was happening was something that we cannot even imagine. And one thing that I picked up from you when we were talking about results is one of your participants said that he or she found creative strategies to navigate these barriers. Again, it comes back to the person with a disability taking on that responsibility and burden to create the inclusion for themselves. And I think we don't understand the gravity of that. It might just seem words, and people think, oh, you're great, you actually navigated this. But then once again, it takes away the responsibility from us as non-disabled people in the community at large in society to make sure that inclusion is happening. So that's important, because I found that in my study as well, that burden, and when I speak to people with disability over the years, is how much that responsibility is on the person with disability, even just in a meeting. So I used to work, my manager was blind, and we'd go into a meeting and she would say that she has to take that responsibility to make herself feel comfortable in the space. People will talk to her and then they'll just move away. And that's a story for another day, why people do that. So I think it's something that we must, it came up a bit again, and it's always something that's there. Again, the issue about knowledge and awareness and the difference in one health facility to the others, and the difference that we made is so critical, and the work that's needed for all of us. I'm reading my own writing now. There's two things, and I don't know how much time I have, but the whole issue about, for example, DCCT not being consulted when, around the whole issue about where knowledge was being around COVID was being passed around in the community. And it's again interesting, they are an NGO that's, working with people who are deaf, they themselves are deaf. And it's again, as I say, interesting why they were not consulted. Again is an issue, but I think it's research for another day. And then before I just wrap up, I just want to know, how did you feel as a hearing person in this research space? How were you, how were you accepted fully? What were your feelings? Because again, I know people with disabilities often a bit skeptical when we non-disabled people come in and now want to do research on them, for example, So what was your experience?
Yeah, I think I had a really great experience. I think in what I mentioned with DCCT, and a lot of people that are involved with DCCT have had experience doing research. So I think a lot of them had either seen it being conducted before, or maybe they'd been participants in past studies themselves. So I think they also were very thankful, thankful and interested that we were doing this research. And a lot of them said that they were very that it was important, and that they really wanted, that they hoped that it would kind of make change. I think that my experience with the deaf community in America made it a little bit less intimidating. I have experience working with interpreters and being around signing people. So it was a little personally a little bit less intimidating than it would be maybe for someone that doesn't have that experience. But I think DCCT's kind of experience with doing research made it a lot easier. A lot of them didn't seem very skeptical. Some of them, a few of them seemed a little bit less open, but I wouldn't necessarily say skeptical. A lot of them were very grateful that the work was being done, asked a lot of questions about COVID, asked a lot of questions about what was going to happen after we did this research. So.
And what after, because your title is really good about making a difference with research. And again, often we do the research and just sit somewhere. So how do you see this, taking this forward? I know it's just a master's, not just, normally it's a PhD that is supposed to find a gap, but in all research that we do, we have an ethical responsibility to take it forward. So where do you see this going?
Yeah, so kind of on a interpersonal level, I have a meeting with DCCT at the end of the month, at the end of this month, to kind of share the findings. We've invited anyone that wants to attend, and I know they had a lot of questions about kind of more details about COVID, so they will be able to ask any of those questions. And then in terms of on a kind of wider scale, I guess, hopefully this will be published. And then we also kept the interviews, the recordings of the interviews that Leslie might use in the future for something, for a documentary or something. Yeah.
Okay. And do you think now that sign language is a top visual language, it'll be any difference, slight difference? Are people hopeful?
I think so.
Yeah. Thank you.
I think it's the first, at least it's the first step. So now the duty is there, and then hopefully that will translate into practice in some ways.
Thank you very much. And thank you.
Thanks, Nafisa. So if I could just make a comment about the way forward. So Nafisa's question prompted Charlotte to remind me. We actually kept the recording, so the idea we'd make an advocacy video. And maybe that's something for Equal Health to follow up. I do want to say that the entry to the DCCT is really Marion Heap's work. So Marion Heap was a postdoc in our school who spent her life's work, basically, second part of her life's work, she was a nurse initially. And her campaign was around making sign language accessible for people in the health service. And to some extent, I don't know the extent to which her work contributed, but we now have sign language available as an interpreter service for any patients attending services in the Western Cape. So we won that small victory.
Small, it's a huge.
But I think it was really Marion's, legacy that enabled this to happen. But that's why DCCT trusts us. It was a Marion, basically. And Marion founded Equal Health, and Equal Health was. Just in terms of implementation, it struck me this morning. I was in a meeting with our registrars, so those are public health doctors who are training to be specialists. And one of them came to speak to me afterwards. She's doing work on developing a package for the health system on albinism. I was like, oh, really? I didn't know that. So actually sitting here, I was thinking that we should actually get Charlotte to present to the health department, and then they can think about, well, actually, this example of like one clinic does services really well because the staff know what's going on, but others don't. That's a health systems question. I'm going to ask you to do that. Let's see who can further follow up. And I just want to make one comment. So we actually discussed whether we would get sign language interpreters for this meeting. It's unfortunate that the DCCT were busy, so they couldn't come to this meeting, but they're going to get their own meeting. But it's actually quite hard to do this research because you don't get interpreters available. You have to pay for them. So UCT, if you're teaching and there's a student who uses sign language, UCT will provide an interpreter. But if you're having a meeting, if you're doing research, you've got to pay for it yourself. So there isn't a lot of institutional support. So we have a policy at UCT about disability, but you don't get a lot of institutional support. And of course, UCT is under austerity at the moment, so that any support will be less. But it does strike me there's a challenge for our own institutions. And I don't think any of the provincial health department meetings ever think about translation. Anyway, so those are just my comments. Are there any questions for Charlotte here in the room? Anyone want to comment? A small audience, yeah. Hannah, over to you.
Two questions. First of all, so lockdown down in South Africa happened rapidly. How did the people get information about that? And I don't recall whether there was a sign language interpreter for the family meetings or the first one. And did you explore, were there instances where they didn't adhere to the lockdown regulation because of lack of information, but have gotten themselves into trouble? And the second question was, can you, knowing the deaf community in the US and in Cape Town, can you see any differences in how the two countries that dealt with the pandemic in terms of infections?
Sure.
So can I just ask if people online heard the questions? Narima? Could you hear the questions, or do we need to repeat them?
No, it's
Okay.
fine. I've heard it, Leslie.
Okay, that's good. Over to you, Charlotte.
Okay. Oh, sorry. Okay, so the first question, or to answer your first question, okay, to answer your first question, so I do think that the family meetings from the beginning had an interpreter, and luckily, or I don't know if it's luck, but South Africa already has that interpreter system set up. So a lot of the news channels they're required to have an interpreter. So they have on, I think even before the pandemic, they have on twice a day. So at 5:30 and at 8 p.m. So that system kind of was already in place. But even though they did note that they were able to get some information, a lot of them only had noted they only had the very, very basic. So they knew that there was a lockdown. They knew they weren't supposed to be out between X time and X time. But because they didn't understand what COVID was, why it was dangerous, what could happen if they contract it, and those kind of details, they didn't really care to stay inside. So a lot of them said they would go out and see friends or whatever it may be, but they didn't really understand the depth of the situation. And then also just even from the beginning and then even throughout the pandemic, a lot of them said that the interpreters only being on at 5:30 and at 8, and sometimes they weren't there. Sometimes like the little box is so small, or there's like regional differences in the interpreter sign language that make that they couldn't understand everything that the interpreter was signing. That also made it a lot more difficult for them to, you know, if let's say they get home at 7 and they have to put their kids down at 8, like they can't, you know, they don't have access to any time, versus obviously hearing people have access to all the time and radio and all of that. And then to answer your second question, I think institutionally on like a government level or a national level, South Africa did way better than the US. So the US has never provided interpreters on screen. They like it's all of that work is up to community organizations to do that. I think the deaf community in the US even sued the government at one point for not providing interpreters. And I think they still didn't provide it. So, and also because there's different states and each state can make up their own rules, there were some states that would have interpreters on screen when the head of the state, when the governor would, sorry, I've been here too long. When the governor would say, like, would make announcements, some states would have interpreters, but they weren't required to. But I do think the one kind of benefit that the US has a very, very strong deaf community and a lot of resources. So they're able to provide, like the community organizations are able to provide a lot more than organizations here. But on a national level, South Africa definitely did better or gave more than the US.
For me, I do not have any questions, but rather just comments around the duty. Basically, you did a very good job breaking on your this topic, because I feel like it opens discussions around some of the topics around the people living with disabilities that have been overlooked. Because I'm just taking from what you mentioned that during, you know, when COVID hit, translators, they were not part of the essential service workers, which is something that should not be overlooked in a system that is working effectively. And it's not only South Africa that something like this was happening, because I have to give reference. During COVID, I was working some of, and those are some of the issues that were also happening. So I really like where your business, your research, your findings are taking us to the advocacy part, as well as some of the questions that a lot of not only South Africa, but other African countries can look at. And I also have to tap into what was said, that the deaf community, they were now more proactive in being, you know, creating platforms of inclusion. I remember at one point they were like the face masks they created where you could see someone speaking, you know, which was very innovative, but it should not be that way in a system. There should be avenues and ways where systems should be inclusive. So,
And do we have any comments from the participants online? Yeah, Griselda.
Hi, Prof. Thank you. Charlotte, thank you for an amazing presentation. I am the Reg that Prof mentioned, who is working on the package of care for people with albinism. So I would really love to chat with you about your findings in, you know, you've presented some of it today, but just to go into it a little bit deeper, so that we could better work this in a way that, you know, people have access to what we offer. So yeah, looking forward to working with you.
Thanks, Griselda. Any other comments or questions from the online? So if not, maybe we just want to. One more.
Oh,
sorry.
Narima.
Narima. You go, Narima. Narima, go ahead.
Can you hear me?
Yes.
Okay. How available were vaccines to deaf people during COVID, given the you know, the difficulties with accessing healthcare and things like that?
Yeah, so they weren't, deaf people weren't, or any person with a disability wasn't prioritized in like the national strategy in the same way that elderly people were, for example. So they kind of had access, I think, through you know, like obviously they could go and they wouldn't be denied, not actually not obviously, but they could go and they would be able to wait in line and get it. And I think most of them heard about where to go through DCCT. So DCCT DCCT shared information on like where the nearby vaccine sites were, what time they were at, the schedule for like how for the age restrictions. So a few of them said that they did just go like when DCCT said it was going to be at X place, they would just go wait in line. They told the nurse or whoever was facilitating that they were deaf, and then they would go get the vaccine. The nurse wouldn't explain any information about it. They would just kind of give it to them and then send them on their way.
It's probably the case that deaf people who were not associated with an organization had less access.
Yeah,
Whether it was
definitely.
DEFSA or DCCT, if you were deaf but not part of an organization or only peripherally connected, you probably had less chance of getting access.
Yeah.
But we don't know.
Thank you.
Okay, so I think we have another hand. Pancho. Hi, Pancho.
Yes, hi. I think my question is simply to ask, you've presented such, insightful work, and thank you for uncovering this for the deaf community. But if we talk about the wider people living with disabilities, is there any attempt to sort of triangulate these data and create a recommendation for the government of South Africa, and of course that could be used by similar countries in the region?
Well, I think you're talking about, for instance, the Convention on the Rights of People with Disability, for example, that Namibia has also signed, is ratified as far as I know. Punches from Namibia, and we would expect a program that conforms to the convention. I don't know. Nafisa, you want to comment?
Yeah, no, I don't think there's any formalized, and that's why I think we talk about research, not just for research purposes, but that we make a difference. And that if we can, in instances like this, work together, get it out there more and see what people are doing, it's actually very helpful for all of us, even us at disability studies. We know that this has been very helpful for us. We could have missed it. But I don't think there's anything formal, but I think it's something that we need to be aware of, that when this kind of research happens, we are sharing it and we're making it visible. And so we know someone like Charlotte and Leslie are focusing on this, and we can direct the stakeholders towards this. So I think it should be something that we will work more closely with and we collaborate. Like, for example, the whole the care package for albinism is something that we're interested to know from the disability studies perspective as well, so that we know that there's something out there.
We need a bit of like a place where we can touch base with each other. Yeah. So Pancha, thank you for that question. And it does also prompt me to think that we can actually collaborate with UCT Film and Media Studies, because their students have to produce pieces of work and they have produced documentaries, and I'm going to contact them and say, here's a documentary, you can work with disability studies, public health, to produce a documentary on the experiences of the deaf during COVID, which will speak to wider disability issues and access to care. How's that? Okay, so I think we are done now. It's 5 minutes before time, but if we don't have any more questions or comments, we should probably thank, there's a clap, thank Charlotte, and thank Nafisa, and thank everyone. We had a really good discussion, and we'll be back maybe a year's time to look at the documentary. Who knows? Okay, thanks all. Bye then.
Bye.
Thank you. Thanks.
So your left hand is like a fist, and then your right hand